my baby cooks her eggplant. She don't read no book. She's got a Gioconda kind of dirty look. And my baby cooks her eggplant about 19 different ways. Sometimes I just have it raw with mayonnaise.
Well, thank you everybody for joining the afternoon session. So we will start off with one of two debates that we have, and thank you for the presenters to be here on stage. So I will try my best for the last name. So Dr. Erzoun and Akar will be arguing for screening for patients who are stage 3 fibrosis for HCC. And on the other team, Dr. Moral and Dr. Birchik will be saying that you should not be screening for HCC in somebody with stage 3 fibrosis. And then why don't we start?
Slides. Okay. Dear Chairman and audience, first of all, we want to thank the organizing committee to having us. Our topic is I screen for HCC in patients with MASH F3 fibrosis. There is no disclosure to declare. AASLD estimated to affect 25 to 30% of the population worldwide, and the estimated global prevalence of MASH approximately 4 to 6%, and HCC is fourth cause of death from cancer, fifth cause of cancer-related disability, and in various studies, the incidence of MASH HCC in non-cirrhotic patients was lower than expected. However, when the mentioned studies are examined, it seemed that subgroup analyses were not actually performed, so mentioned numbers are not valid for F3 fibrosis. It has been reported that 15 to 40% of patients with MASLD-related HCC are non-cirrhotic, and 27 to 38% of these patients have advanced fibrosis. These are completed and ongoing randomized controlled trials for MAPLD treatment, and most of them are focused on MASH with fibrosis. And why is F3 fibrosis is important? Because high risk of progression to cirrhosis, increased risk of HCC, early detection significantly improves survival, and late-stage HCC has poor prognosis with limited treatment options, and screening enables curative treatments. Various major adverse liver outcomes may develop in patients with MASH. As the degree of fibrosis increases, the development of MALO accelerates. Approximately 30% of patients with MASH will progress at clinical hepatic endpoint by 15 years. As the degree of fibrosis increases, mortality increases, and in 20% rule for fibrosis progression, over 2 years, 20 of patients with F3 progress toward F4 fibrosis. And the fibrosis increases and liver-related mortality increases. This is an Australian article. It's highlighted here that 3% of people with MAPLD and 17% of people with MASH will develop HCC during their lifetime, and targeted routine liver surveillance has been shown to reduce the probability of death from HCC in MASH patients by 27%, while also improving cost effectiveness by saving $16,000 per life year and reducing resource burden. This is a prospective study, a total of 1,073 patients with MASLD and 369 patients of this F3 fibrosis. As you can see, the cumulative probability of developing HCC was higher in F3 fibrosis than early stage fibrosis or even cirrhosis. MASLD HCC in non-cirrhotic liver more frequently had a larger nodule size and greater rate of recurrence than those with cirrhosis. More than half of MASLD HCC cases are found incidentally, usually in advanced states beyond Milan criteria for liver transplantation and no longer enable to curative treatment. Routine HCC surveillance can reduce HCC mortality by 18% in MAPLD patients and MASH F3 patients at 22% risk of developing cirrhosis over 29-month follow-up. The risk of HCC is increased 2.5-fold in pure NASH, while there's up to 10-fold increase in risk with advanced fibrosis and cirrhosis. There are some risk factors for HCC in non-cirrhotic MASLD patients. The risk of developing HCC also increases in those with high-grade fibrosis, diabetes, obesity, older age, alcohol intake, smoking, FIB4 greater than 3.25, and liver stiffness measurement greater than 10 kilopascal and increasing change in over time. This is a Greek author's treatment, not treatment, algorithm proposed for HCC surveillance in MASLD patients based on guidelines. Accordingly, they recommend screening with ultrasonography and or AFP level in those with F3 fibrosis. In this algorithm proposed by Japanese working group for HCC surveillance, it stated that firstly, early stage and advanced stage should be distinguished using the lower NITs. Then high-risk patients with advanced fibrosis should be identified, use the upper NITs, and strict HCC surveillance should be performed in these patients.
Thank you, Chenjan, for your presentation, and I'm going to continue with the current guideline recommendations about this subject. The AASLD guidelines doesn't have a general recommendation about screening for F3 fibrosis patients, but they are recommending screening for high-risk patients in F3 fibrosis, and AASL doesn't recommend screening for F3 fibrosis patients at the last guideline, and Japanese guideline is supporting to us. They are recommending screening male patients with F3, 2 or 3 fibrosis, and female patients with F3 fibrosis with abdominal ultrasound in every 6 to 12 months. And what about Turkey? I'm going to talk about our daily practice for HCC screening and what should we do in our practice. The HCC incidence in Turkey is increasing between 2014 and 18 for men and women, and there is no specific recommendation about screening F3 fibrosis with muscle in Turkey right now, but we are screening all cirrhotic patients in any kind of etiologies with abdominal ultrasound and AFP. And as Shenzhen mentioned before, there are some contributor factors for HCC development in muscle patients, and diabetes is one of the important contributor factors for that. And as you see here, Turkey is the most diabetic country in European region, and the rate of diabetes in Turkey is also high for the world. And the other one is obesity is the most important contributor factors, or one of the most important contributor factors. And Turkey is also most obese country, the second most obese country in Europe, and also the rate of obesity is very high for the remaining part of the world. This study is from the Turkish Journal of Gastroenterology about changing etiological factors in cirrhosis in Turkish patients, and approximately 5,000 cirrhotic patients from Turkey in this cohort. As you see here, muscle and alcohol consumption is increasing sharply in last 10 years, and hepatitis B and C is decreasing. And there is a very important result from this study. Muscle-associated HCC was the second most prevalent type of HCC in this cohort. There are 538 HCC patients in this cohort, and muscle-associated HCC was the second most prevalent type of the HCC patient in this cohort. If we do fast back to world data, this is compatible with the Turkish data. The global proportion of HCC secondary to NAFLD is increasing in the world, like Turkey. And the hepatocellular carcinoma patients associated with MUSCLed are more non-cirrhotic, and they are not underwent surveillance before diagnosis. Just 32% of NAFLD-associated HCC patients underwent surveillance before the diagnosis. And this is another study from Turkey about hepatocellular carcinoma patients' characteristics. Approximately 550 newly diagnosed HCC patients, at least 2.5 years follow-up, and approximately 50% of patients were under follow-up with former diagnosis of cirrhosis or hepatitis, just 50%. Also, HCC was the first diagnosis in 50% of the patients. And referral patients directly diagnosed with HCC had large tumor diameter and more advanced stage. So we can say we have insufficient awareness of HCC risk factors, and we have poor adherence to screening practice in cirrhotic patients. Even there is a recommendation for screening in cirrhotic patients in Turkey. And the other very important subject for screening F3 fibrosis patients, cost effectivity. But as you see here, the diagnostic tools like AFP, US, or MRI, or liver biopsy, the price of diagnostic tools in Turkey are very, very low when you compare the world. And as you know, our patients mostly have social insurance, so there is no specific study about that for Turkey, but we can say we will not have a cost effectivity problem for that. but we should keep in mind, of course, screening may be more expensive in muscle patients, muscle-associated cirrhosis patients because of the fatty liver and low ultrasound quality. But if we need MRI, the MRI price is also very low when you compare the remaining part of the world. And this year, 1 million new HCC case is expected, and non-cirrhotic NAFLS HCC patients account for 6% of these groups. So if we excluded these patients, if we don't screen these patients, every year 60,000 HCC case being missed. It is a very big number, I think. And we have a poll on X platform about that last night. And the hepatologists and gastroenterologists from Twitter are agree with us. Thank you for your attention.
Oh, yeah. Maybe we could have the opposing team. Thank you.
Slide alabilir miyim? Thank you very much for this nice presentation. So we are on the other side. I'm Kenan Mural, and
I'm Dr. Şefik Cembircik. We are both gastroenterology fellows.
And we are against screening. So short introduction, as Hassan previously said, MASLD is a worldwide problem, affects 30% of the population, and MASLD accounts for up to 35% of ACC cases worldwide. The incidence of ACC in MASH patients with cirrhosis is high. The annual incidence is around 1.5%, but ACC incidence in patients without cirrhosis is still low, 0.08 per 1,000 person year. But we know that there is a high proportion of MASL patients without cirrhosis who have ACC. What's the problem? The problem lies actually in the ACC incidence. If you're looking at the cirrhotic stage, we have a high incidence, 10 to 15 per 1,000 patient years. And if you're looking at the NAFLD stage, or MAFLD right now, it's 0.08 to 0.63. The in-between case where we have the metabolic associated steatohepatitis stage is a little bit problematic because the studies are problematic and they are too heterogeneous. So what do the guidelines say? The guidelines, as they also mentioned, AASLD is against screening in F3 fibrosis, and AASLD guidance from 2023 is also against routine use of ACC surveillance because there are not enough studies to say that it is cost-effective to use ACC surveillance in those patients. Only the clinical practice update in 2020 recommended to screen for patients with advanced liver fibrosis. So a systemic review meta-analysis in 2022 actually made here a pooled incidence of ACC in patients with cirrhosis, which is 4.62 per 100 person year, which is very high. And if you're looking at the patients with non-cirrhotic patients, we have a very low rate of ACC incidence per 100 person year. Another study here from 2018, as you know, here when we have no cirrhosis and no high FIB4 score, we have a very low incidence. If the score is a little bit more high, but without cirrhosis diagnosis, again, we have a 0.39 percentage per 1,000 person years, but if the patient is cirrhotic, it increases tremendously. So the studies, the incidences for ACC per 1,000 person year doesn't make sense to actually make surveillance in those patients. Here again, studies of really big cohort studies, large studies, one from the veteran study in the USA, 0.08 per 1,000 year, the other one 0.46 per 1,000 year, and again here in the Japanese study 0.43, and in the last study here 0.62. So all of them are below the threshold for ACC surveillance. So in the literature, when you know, if you look, this is from the 2018 AASLD guideline for ACC. Here we have a threshold incidence for 1.5 percentage per year, and NAFLD patients without cirrhosis have an incidence below this threshold. So This is also the reason why the guidelines still doesn't recommend screening in those patients.
If we surveil too much patients, we would get a lot of abnormal images. This is why we put this slide. 1 in 4 patients enrolled in HCC surveillance programs had abnormal imaging, and 3/4 of these abnormal imaging lesions were intermediate nodules. So these would result in downstream harm for the patients. We need to find risk stratification tools to identify nodules that are benign to reduce follow-up harm. In this HCC surveillance patients with cirrhosis article, over one of 4 patients with cirrhosis experienced physical harm or false positive or indeterminate surveillance tests, mostly related to ultrasound, not AFP, and interventions are needed to reduce surveillance-related harms. This slide shows that we need to use our resources to cirrhotic patients. In surveillance programs of 118,000 patients, even cirrhotic patients were not surveilled enough. Only 24% of them were screened for HCC. When they did subgroup analysis, they found that gastroenterology and hepatology clinics did a better job than population-based cohorts. 73% of them screened enough for HCC, but population-based cohorts were 8%. So we should use our resources to cirrhotic patients. We can't even screen them enough. And in this systematic review and meta-analysis, the data of F3 and F4 patients, which is advanced fibrosis, is pooled together. The data is very heterogeneous, as we see, 93%. That's why advanced fibrosis F3 and F4 should be separately evaluated in the literature. We can see that it's 2.2% versus 217% per 1,000 hits, and this is a very heterogeneous meta-analysis. What does World Health Organization say for cancer control and guidance programs? Cancer screening strategies should be cost-effective, targeted toward very well-defined populations. They should minimize false positive testing, avoid psychological harm from such a public health policy. They may, if you do screening to everyone, we would come up with financial crisis, physical harm, psychological harm. If we detect a lot of false images in these screening programs, this study shows that 10% of the image-guided liver biopsies result in minor bleeding, and 0.1% to 4.6% of the images biopsies result in major bleeding. When we divide F1, 2, 3, 4 patients separately, not like advanced fibrosis and non-advanced fibrosis, we see that F3 is closer to F2 here in free of liver transplantation survival. F4 is definitely separated from these other fibrosis levels. And survival of free liver-related events, we see that F3 is close to F2 here, and F4 is separated again. As Ion now said in 2021, fibrosis level is not enough for only detecting to screen or not. We need a good stratification model that would take a lot of things to account. So in conclusion, why we don't want to screen F3 MASH patients? Bad cost effectiveness, low incidence of HCC, physical and psychological harm. We may induce contrast nephropathy, radiation exposure harm, biopsy-related harm, psychological harm.
Yes, and using our resource sources to higher risk patients, as he said previously, that the normal cirrhotic patients doesn't have a fully good HCC surveillance program. Another question here for the other side is, if we screen F3, why not screening F0 to F2? Because they are also patients who develop HCC in this subgroup, and there are no prospective or non-heterogeneous studies, homogeneous studies, supporting the screening in F3. Guidelines do not recommend screening. And our last, of course, message is risk stratification models must be developed, like the PHP score, for example, to really detect the high-risk group within those patients and put them under surveillance. Thank you very much.
So maybe before, actually, oh, you have a microphone. Okay, so maybe people can come up and ask questions. That would be, I think, great. But I'll start with a question. So pretend we are 5 years down the road, and you had to select. So is there a subgroup of patients with cirrhosis that you would perhaps relax screening on? So not every 6 months, maybe annually or less.
Yeah. A subgroup of patients where we should do surveillance. So
no, so in cirrhosis, we all agree that every 6 months you should be screening for HCC. Is there a group of patients, hypothetically, that you may have tools in the future that you maybe don't have now that would allow you to restrict, because you were talking about resource utilization, you're sort of restricting your, or saving resources. Is there a group of patients that you think are at lower risk, essentially, of HCC that you could envision in the future screening less often?
Okay, yeah. For cirrhotic patients, I think it would be a little bit too risky if there are no studies to refrain from screening. But for patients, of course, in the F3 fibrosis group, a risk stratification model must be developed in order to detect those ones which should be screened and those ones which shouldn't be screened. Yeah.
Maybe ones with low FIB-4 score, negative PNLP 3A, non-obese, non-diabetic, no alcohol, no viral, a lot of negatives.
Okay, thank you. And then for, actually, do you want to? Go ahead. No, go ahead. Go on.
No, just for the pro team. How do you think, the con team raised the argument that, you're saying screen so many people. Do you think your system can handle it?
Yes, maybe, as Kenan said before, there could be find non-invasive or more basic risk stratification models for these patient groups, and after then maybe we can start to screen.
Maybe as a follow-up to that question, so because the majority of people with stage 3 fibrosis are actually not identified, so probably 90% are not identified, and you're going to screen them, how would you sort of implement that, and what non-invasive tests, like what thresholds might you use to identify those patients? Because you can't screen everybody, right? Or, it seems difficult that you could screen everybody, but how would you identify those patients with F3 disease?
How I couldn't understand.
So what tests might you use other than liver biopsy to identify patients who have F3 disease that you would like to start screening?
Mm-hmm. Some kind of non-invasive test maybe before liver biopsy, GALAT score, or some new biomarkers could be fine. And yeah, elastography or yes, MRP-ADFF before liver biopsy. I think we have so many options for screening these patients.
So both of you heard each other's arguments. Do you have something to say to the con team and then the con team for the pro argument?
Okay. What do you do for F3 fibrosis patients in your daily practice in Turkey?
So in reality,
No.
in the reality, I'm using, of course, FibroScan score, FIB-4 score, looking at the metabolic parameters if they're right, and following them, of course. The question for HCC surveillance, if you're asking directly, actually, I am doing surveillance every 6 months, even though I'm against the group. It's the reality. But evidence-based studies are lacking in support of this. Perhaps it's only a way of doing it for psychological way of why we should not do for this patient, because it's very cheap and so on. Yeah, that's a problem. But let's put aside the psychological compensation methods, what we're doing, or a relationship with the patient. What's the evidence? So when we are screening F3 patients, why not F0 to F2? Because they are also developing HCC. So what's the evidence? And the threshold is very low for screening HCC in patients with F3 fibrosis. So there is no any evidence. What's your evidence to do this?
Yes, I think there is a need for this area. There is a need for studies and new studies for this area, and maybe somebody or we can do the studies for the subgroups like F3, F1, and F2. But I agree with you. There is no strong evidence for that. In my routine practice, I choose patients with high risk stigmata like diabetes, obesity, or some portal hypertension signs, actually.
So I think we're going to close very soon, but since we didn't get, we don't have information on how we're supposed to judge you, we decided that we're going to ask for a show of hands, but not yet. We're going to ask for a show of hands, and if it looks broadly similar, then we're going to discuss and let you know. So importantly, in a debate, what matters is how it was presented, because both arguments could be made. So I just keep reminding you of that. So I guess for the pro team, you should be screening people with pre-cirrhotic stage 3 fibrosis. Can I see a show of hands for who thinks that this was the winning argument? Okay, and just to confirm, those of you who do not think we should be screening pre-cirrhotic MASH, please show your hands. So a lot of you don't know.
So it's 10 versus 3.
Okay.
So wait, if I had if my mom had stage 3 fibrosis, who should I come to see?
All right.
Yeah, give us 1 second.
Give us 1 second, okay? We're going to discuss.
I guess the winner is going to get a free trip to Paris, right? Is that what you said? So you say the con team?
Yeah. Okay, so the prize of the day, which is a trip to Paris, will go to actually the don't screen, so just screen cirrhosis team. So congratulations, you guys both did a great job.
And then, thank you so much. And then we'll continue with the session. Please feel free to, okay to head out. We'll just switch the order. Dr. Rinella is going to talk first, and then I will talk after that. So.
Okay. Okay, so hopefully this is okay that we change the order a bit so that we can get the slides uploaded for the next presentation. So what I was asked to talk about was MET ALD. Again, here are my consulting disclosures. So MASH and alcohol-related liver disease have many common pathways, initially distinct pathways in how you develop steatosis, but these converge into common pathways when it comes to inflammation and the development of fibrosis over time. So there are also significant similarities in histology. I would not say that they are identical. In alcohol-related liver disease, you see a more acute injury pattern with more polymorphonuclear Actually, you can see here an example of satellite ptosis, which you rarely see in MASH. Both share ballooning, both share inflammation, just lymphocytic inflammation. So with respect to the role of alcohol and in metabolic dysfunction and promoting disease progression, you can see that there are numerous factors that are actually quite common to alcohol and metabolic liver disease. In fact, the vast majority of people with alcohol-related liver disease do have cardiometabolic risk factors, and some of these are direct effects, for example, on blood pressure and dyslipidemia, and to some extent also to the pancreas. So these two together converge and can create significant augmentation of liver injury. So the rationale for the creation of a new nomenclature and development of this category was based on that concept, and also the fact that alcohol is very common. In fact, alcohol intake is actually very significantly elevated, and you can see, I guess, if you live in the United States and parts of Europe, the majority of the population are consuming alcohol. And the amount of alcohol is also sizable in some countries in particular. So it's a reality in many societies that we need to address. And in conjunction with this, obesity and metabolic syndrome is also increasing significantly. So now you have increased alcohol and increased metabolic load, which in conjunction are going to lead to more significant liver injury. So you can see this sort of manifested in liver transplant. The indications for liver transplantation, you can see MASH and ALD are up there neck and neck with respect to etiologies requiring liver transplantation. In the US, we don't see much in the way of Hep B transplants. Hepatitis C, we used to, of course, see quite a bit, and now that's significantly decreased with the effective therapies. So there's a significant impact of alcohol, and now we know that even small amounts of alcohol increase your risk of cancer. But if you look here, for example, if you look to the right, you can see that even just one drink a day in the setting of significant metabolic burden is equivalent actually to drinking 4 drinks a day if you have a normal waist circumference. So these two factors really can sort of augment one another. You can see also to the left that whether you have metabolic syndrome or you don't, the amount of patients with liver-related outcomes goes up significantly with more alcohol intake. So a little bit on the nomenclature, you can see here that there's been a sort of an evolution over time. The development of MASLD came out of a issue related to the inclusion of alcohol without an upper limit in the MAFLD diagnosis, in addition to a few other things that led us to lead this process to revisit the new nomenclature, and out of that came MASLD and MET-ALD. So through the 2023 consensus process, this was a 3-year-long Delphi process involving representatives from 56 countries with a panel of 272 participants. And what we came up with is a category of patients who have metabolic dysfunction, who have metabolic features, but who also drink more than the allowable limit in what was NAFLD, now MASLD. The reason why that was so important is because if you make that, if you include more alcohol in the MASLD group, for example, you change the natural history, and that's what we were concerned about with MAFLD. If you take it to the other direction, you're going to have a significant impact on the natural history, and if you take it completely away, sorry, I said it backwards, you can't interpret prior studies. So we had to keep the prior alcohol limits for MASLD, and then we wanted to add a group that drank a reasonably high level of alcohol. This would be considered high alcohol intake based on many alcohol-related associations. So in any case, that was the rationale behind the creation of that group. So the alcohol attributable risk in steatotic liver disease is quite significant, and you would argue that the more alcohol intake, the more liver disease and more liver disease progression you're going to see. It is a more important factor with respect to rapidity of development of fibrosis than are metabolic risk factors. So again, the lower threshold was bound by the NAFL definition, and that's 20 to 30 grams, 20 for men, 20 for women, 30 for men daily, and the upper threshold was set at 50 for men and I keep saying that, 50 for women and 60 for men. So the prevalence of steatotic liver disease in the United States, as it is here, is quite high. These are data from the NHANES population cohort, and you can see here that approximately 30%, 32% had MASLD, 2.56 had Met-ALD, only 1.14% had a combination etiology. Other than this, only 1.17% with alcohol-related liver disease, and of course that doesn't make any sense. I really believe that Met-ALD is wildly underestimated in some population-based studies, certainly in this one. And especially when you look at alcohol-related liver disease, that would not make sense with what we see in transplant, for example. So does this have any prognostic relevance? So one of the earliest papers to look at categorization of SLD into MASLD, Met-ALD, and no SLD was the Odense group here. On the left, you can see that there's incremental risk with respect to hepatic decompensation with increasing alcohol use. Again, fairly intuitive. And to the right, you can see another study demonstrating the same very significant hazard ratio once you hit Met-ALD compared to MASLD or no steatosis. So this is, though, a very dynamic spectrum, and we'll touch a little bit on how this might fluctuate over time. But as you can see, the more cardiometabolic risk you have, and perhaps the more genetic risk you have, the higher your risk is going to be. And then if you compound that with increased alcohol, you're going to see very significant differences in the risk of decompensation over time. So interestingly, this is a really nice study from Spain. Although the definition for advanced fibrosis was a bit low, in my opinion, its threshold was at 8 kilopascals on BCTE. You can see that even within the MASLD category, so even within the allowable limits, you can see a very significant increased risk of fibrosis when patients have high cardiometabolic burden. So again, this theme that high cardiometabolic burden and increased alcohol intake are really going to get patients in trouble, and that's also the case for at-risk MASH. So how might we assess alcohol use? So there are several ways to do it. We generally use PEth more than the ETG, urine, or hair, at least in my institution. PEth is phosphatidylethol, and it is basically a byproduct of metabolism of alcohol and is specific to alcohol intake. It's also quite sensitive, and it basically captures about 3 weeks of prior alcohol intake. So this really, at least, seems to be borne out in the literature as the most reliable biomarker. You can see above in the dashed lines, you see self-reported alcohol intake, and on the solid lines, you can see high PEth, low PEth, and self-reported on the top. Sorry, I can't even talk. So in any case, what we think is that for low levels of alcohol intake and for the context of a clinical trial, initial questioning with, say, an audit C, for example, is probably sufficient with self-reported alcohol. Once you get into heavier alcohol, PEth really can be a useful tool. One of the big issues with the categorization is that, again, this is a really dynamic process. So Alcohol intake is also very dynamic. There are periods of time when patients may be drinking a lot and others where they're really not drinking much at all. And this is demonstrated here, and this is also in part also data from the Danish group. So here, 35% over a period of 7 months changed their alcohol intake, meaning they changed categories of thresholds of alcohol intake. And then this also is true for metabolic burden. As you can imagine, diet, exercise, sleep, concomitant drug use, et cetera, can impact your cardiometabolic load. And so this is a bit of a moving target. Here you can see these are data from Denmark as well, and you can see that there are changes in categories, again, very dynamically over time. So how do we get around this? So what is recommended, and this is a paper that I think is now published, you can see that there's a clinical things that you need to do, and asking people about their alcohol intake is very important. I think that we were not doing that enough. And then trying to get a sense for not just the quantity of alcohol, but do they have any evidence of alcohol use disorder? Using an audit C is very quick. It's only 3 questions. That can give you some good insight. But generally speaking, at least as of right now, we're considering MET-ALD to be defined within a PEth range of 20 to 200. Some would argue 40 is probably a better range, but 20 to 200 is what we're using, at least for now, operationally for the design of clinical trials. And then, of course, MASLD and management of cardiometabolic risk factors is also very important. So audit is a validated questionnaire, which I'm sure you're all aware of. It's comprised of 10 questions, and the score ranges from 0 to 40, with a low-risk cut point at less than 8. So the change in audit score has been linked to liver-related outcomes and has a very high negative predictive value. Audit C is a 3-question screen, which I think is also good and is much easier to do in the office, especially if you have limited time. Skip that. I think we have an old version of my talk, but so why is it important to identify alcohol use disorder? Because you can actually intervene effectively. So if there's no alcohol use disorder, that's great, then you can move on. But if you have evidence of mild alcohol use disorder, these patients respond very well just to brief interventions with motivational discussions and interviewing, and you can actually curb and change their trajectory. Once you have more severe alcohol use disorder, you really do need more specific therapy to help those patients. So with respect to management of the patient with MET-ALD, we should always take a patient-centered approach really for everything, but specifically here because it's really going to be a combination of lifestyle intervention, as we've been discussing all morning, alcohol management, so identification of alcohol use disorder and education of the patients that even small amounts of alcohol can be damaging. And then we will have hopefully some therapies in the MET-ALD space. This is a very significantly growing field of investigation, which is one of the most exciting things I think that came out of the new nomenclature. So as far as takeaways, progression of MET-ALD is largely driven by alcohol intake. Even low to moderate alcohol consumption is associated with fibrosis progression and adverse outcomes. And you do need to screen for alcohol. And again, we have some exciting compounds that are going to hopefully be effective in this population. And with that, I will close. Thank you very much.
Thank you, Dr. Rinella. We're going to have the questions later on. And we continue with Samit Kayashrai. He's going to talk about the TMD debrief, alcoholic liver disease.
Thank you again, and thank you, Arden, for the help with the slides. This second update is highlighting some of the abstracts that were presented at the liver meeting about 2 months ago, and sort of follows along with what Dr. Rinella was talking about, and hopefully builds on some new concepts. So there were three different types. We'll talk about some papers that looked at epidemiology and what's changing. Second one is updates in treatment. And then the third part is the role of alcohol use disorder and how should we be more aggressive about it. So with regards to with regards to sort of the epidemiology, this was a US-based study. And would love to get a comment of how we feel things are changing also in Turkey. Orange is US, and then green is global. So what is seen is that the number of patients who have alcohol use disorder in orange in the first panel has increased. Alcohol-associated liver disease has also increased, and same thing with liver cancer from alcohol in older individuals. And so a couple of caveats about this is, we also see those two spikes. One is the younger patient who's late 30s, early 40s, who comes in with alcohol-associated hepatitis. And then the second group is the mid-60s that we see often in our practice, the patient who has other, the factors for met ALD. So that's one. And even though the global rates have been shown to be decreasing, the question is how much of this is unrecorded. At lunch, we were talking about how people are making alcohol at home, and that is not reflected in this. So I think alcohol just globally remains, of course, a big problem. Second one is mixed picture. So here were 4,000 patients where were just called alcohol liver disease. But if you really looked at it and said, all right, how many patients have risk factors for hypertension, dyslipidemia, diabetes, BMI, again, what Dr. Rinal was commenting on. And it turned out that a majority of patients had more than one risk factor, where 20% had one risk factor, 26% had two risk factors, and 1 out of 5 had all 4 factors. And diabetes here was the only risk factor independently associated with cirrhosis. And patients whose only risk factor was BMI 25 to 30, they did not differ from the pure ALD cohort. So the message for me from this is that oftentimes now we're going away from seeing the pure ALCAP patient, and it sort of becomes co-management of both those factors to help the patients long-term and vice versa. And hence you may, of course, see translation of medications that started off in the MASL field more coming to ALD also. The importance of BMI remains, and this has been discussed even in the past 10, 15 years ago, similar studies talking about BMI. The concept here is how does BMI impact your outcome after first decompensation? So I'll walk you through this. So here was a study from Japan, 100 patients who had the first decompensation episode, and the decompensation episodes are given in the pie chart. Majority were ascites, some were multi-organ failure, some were hepatic encephalopathy, so a mixed bag. And of these, 27 had a liver-related death, and then 10 died from other causes. If you look on the right, in terms of the first table, with regards to the all-cause mortality, as expected, if you continue to drink, if your MELD score is high, if you have ascites, you don't do well. But similarly, BMI also impacted. What we don't know is if the BMI was adjusted for ascites, but regardless, seems like BMI is an independent predictor of mortality. And then looking at the factors specifically for liver-related mortality, similarly, the more decompensated you are, in addition, thinking about obesity as an independent risk factor there. If you broke it down by your outcome over time, the 4 panels sort of show the same kind of pattern where the difference between your outcome, drinking versus non-drinking or reduced, versus T-bili versus less bili or ascites. And what you can see is for BMI, the magnitude of difference between those with high BMI and low BMI is about the same as decompensation. This scares me because I'm above BMI 25, so I need to watch it. Obesity in alcohol-associated hepatitis. Here was another study. So there's another network called ALCAPNet, and ALCAPNet combines 2 different aspects. One is a government-sponsored randomized controlled trial, as well as an 8-center observational study. And here the question was, again, what are what is the impact of obesity on survival. In the left panel on adjusted analysis, what you see is obesity, again, remains an important independent factor, even after adjusting for MEL score and how old you are and whether you get steroids. And on the right side, it just shows you the percent mortality. So if I just compare obese versus normal, in this case, it was just defined by BMI, is 90-day mortality in patients with normal weight was 14%. In obese, it was 27%. And if you look at multi-organ failure all the way to the right, it's 25% versus 40%. So again, same theme of even in the sicker patient, decompensation, as well as alcohol-associated hepatitis, obesity playing a role. Finally, with this aspect of early return to drinking, these were patients who ended up being admitted for ALCAP, and then how many returned to drinking? About 1 in 4 returned to drinking, and 1 in 3 patients go back to drinking within 6 months. And so your window of really helping our patients is immediately after they get released. And so the question is, as hepatologists and gastroenterologists, we're good at treating the medical aspect, but I think linking patients to care for treatment of alcohol use disorder, this study is saying the earlier we can intervene, the better. And hard patterns at the bottom is that the longer you're drinking, of course, it's harder to quit. But even with those with less college education, were associated with early return to drinking. And the challenge sort of for us is, the same skill set or the tools that we provide somebody with more education may need to be tailored to somebody with less college education so we can help the population at large, because that is the population that ends up in the hospital. Switching to some updates on treatment that were discussed at the liver meeting. One was GLP-1. So this has been the theme sort of the morning and early afternoon. And the question is that if you have a patient, again, with ALD and type 2 diabetes, and they were on GLP-1, what is their liver-related outcome? So in this, the study of 14,000 patients, retrospective, where you had about 2% who were on GLP-1, and most of them, of course, were not on GLP-1, looking at development of liver-related outcomes. In this cohort, about one out of 3 developed hepatic decompensation, 4% developed HCC, 16% had some portal hypertension. And what you can see in the figure below, the blue, which is the lower one, is patients on GLP as compared to no GLP. And it appears that the risk of hepatic decompensation is lower. So patients taking GLP-1 receptor agonist were less likely to develop hepatic decompensation, 22% versus 33%. So, and then HCC rate was also lower as compared to those not taking a GLP. What we don't know is how early did these patients get started on these medications, and was that a factor? The sicker the patients maybe just were not ready to get treatment. Coming back to bariatric surgery, what about bariatric surgery in patients with combined metabolic dysfunction and increased alcohol consumption? So does bariatric surgery improve liver-related outcomes in med-AD patients? Once again, a large database study, 160 million patients, looking at those with undergoing bariatric surgery versus no surgical intervention. The primary endpoint was, which is the first figure, where the curves overlapped, was the incidence of decompensated cirrhosis. That was about the same in both patients, suggesting some kind of selection bias. But if you look at the overall mortality on the right, which is showing just any patient who had a surgery versus not, and had increased alcohol consumption and metabolic dysfunction, the mortality was lower in those patients that had undergone bariatric surgery. Another clinical question that comes up is how do you give steroids during an admission for alcohol-associated hepatitis? So per guidance, it's, you give one fixed dose for 3 to 4 weeks and then stop. And this study looked at 2 different approaches. One is if I just stop after giving 3 to 4 weeks of high-dose steroids versus I taper. First week is 40, then 30, then 20, then 10. and which approach really works. So here patients were defined by, again, the NIAAA definition. Patients had to be MELD higher than 21 and managed per institutional protocol. Discriminant factor above 32, so severe alcohol-associated hepatitis, no infection. Patients got N-acetylcysteine, albumin, antibiotics, everything else per institution, and then were randomized in an open label to either fixed dose prednisone for 40 milligrams or a tapering dose. Then you had risk stratification at day 7, responders versus non-responders, and then accordingly, if they were responding, then either you continue with 40 or you continue with a taper 40, 30, 20, 10. So with that context, on the left panel, the survival for both approaches were the same, whether you get a fixed dose or if you give a tapering dose. On the right side is that giving the fixed dose, which is in red, came at a cost of higher rate of infection. So, and the difference was pronounced after a month, where patients who got the tapering dose did fine. They had the same survival and a lower risk of infection. So this could be one takeaway, practical application that even if you taper over the first month as an outpatient, it's okay, and the survival rate would be about the same. New agent, I'm still trying to figure out how to pronounce it. This was a direct study, and what this looked at is larsucosterol, or somebody probably says it better. That agent right there. For treatment of severe alcohol-associated hepatitis. So we were one of the centers that participated in this study, and this was dose-finding study also, looking at patients who were in our hospital MELD above 21 but less than 30. So it was pretty restricted, only 21 to 30, and 300 subjects across 60 sites. And it was after screening, you either get a 30 milligram dose, 90 milligram dose, or a placebo. Now, even in the placebo arm, you were allowed to give steroids if you wanted. So not a complete comparison, but regardless, if you look at the doses, so most patients just got one dose, and if the patients were still in the hospital by day 4, you got a second dose, and then you follow them for 90 days. And so with that intervention, and the mechanism is, this is a DNA methyltransferase inhibitor, and the thought is that maybe it causes some epigenetic changes or modulation, and that could be a different mechanism for this. And the primary endpoint was 90 days with the patient's mortality or liver transplant. And this study did not meet its primary endpoint, even though this looks amazing. But again, it's the p-value here was 0.07, did not meet its primary endpoint. There was a 40% reduction with the 30 milligram tablet, and then the 35% with the 90 milligram tablet. So about, the risk goes down by about a third, but again, not significant. However, in secondary analysis, and this is probably going to form the basis of the next study, is what they saw is that globally, it did not help patients, but for some reason in the US, it really helped patients, where this in subgroup analysis, where the mortality was lower by about 60% in patients who received this medication at the US centers. The question is, what is driving this this improvement? Is the thought is early administration. So if you think of the dotted line as around, I think about 10 days or 11 days, the vertical line, and in the U.S. seems like the administration was mainly of the medication before day 7, whereas globally it was like day 10 or day 11 or day 13. So could it be that patients were selected early enough to get the intervention, and those are the ones that got a benefit from it? So more to come. There's going to be a phase 3 study, I think, a plan for that, for this. But again, the caveat being is that potentially signal here, giving it early, another study coming. Now, the flip part, and more emphasis on treatment of alcohol use disorder. The themes of involving our addiction psychiatrists, psychologists, came up. And the question is, how much can we also do as hepatologists to sort of, help our patients for the alcohol use disorder component? Because as you can imagine, that's the biggest driver here with patients coming in for alcohol-associated complications. This was hinted at before about the brief intervention. And brief intervention is sort of, once trained, this is, all of us can do it. This is, 10 minutes to 30 minutes, depending on time, or multiple sessions, where brief intervention is a combination of sort of feedback on the biofeedback for the feedback for the patient, motivational interviewing to sort of see if those brief interventions can help decrease the risk of liver-related outcomes. And here the combination was that you have a patient who came in with unhealthy alcohol use, defined by the audit C. And then what the patient got was transient elastography via FibroScan plus the behavioral intervention. You discuss the results. You have the social worker or somebody on your team meet with the patient and to say, here's the implication. Not only is this an alcohol use, but also is affecting your liver. So really focused discussion by multiple members of the team talking about the same kind of thing. So personalized liver biofeedback using both scan plus brief intervention. Things we probably informally do anyway in our practice, but this is really formalizing it in terms of an intervention. And what was seen is that in 3 months, if you look at risk score by WHO criteria, that actually decreased, as in 40% decreased their WHO risk, and 45% by 6 months had decreased the WHO alcohol risk. So even just spending some time formally discussing the alcohol use disorder, along with discussing the results of elastography, can be a wake-up call for many patients, and this may have led to decreased hazardous alcohol use. What about naltrexone? Increasingly, I think us as hepatologists are getting more comfortable using it in our practice. And here patients were divided into 2 groups, just looking at those who had gotten naltrexone versus no naltrexone. Again, a big, sorry about this, large cross-sectional, prospective study, of a retrospective study. And patients who received naltrexone in this figure had a lower incidence of decompensated cirrhosis. And then exposure to naltrexone was also associated with decrease in mortality. So naltrexone, again, playing a role, and more later studies now showing that even in decompensated cirrhosis, early decompensated cirrhosis, it is safe to use. Here's a study showing in decompensated cirrhosis and ascites and looking at relevant clinical outcomes. So the columns are naltrexone versus no naltrexone in the yellow/orange. What you see is that future decompensation is also surprisingly lower in patients that receive naltrexone. So likely patient selection, but what you can see is that patients are motivated enough and can maybe stay on the naltrexone. There may be a benefit even from a liver standpoint for their condition. And then finally, last slide. This is a future cast of where we may be going. We discussed one scenario with the fellows of how more and more smartphone can be used to give you personalized addiction therapy and identify if you're high risk or not. In this was just a sort of a tease that where this group developed sort of CBT-based therapy using ChatGPT, motivational interviewing, combining it with a virtual reality headset, and having somebody, an AI-enabled conversational agent in VR for patients with alcohol cirrhosis. And is this the future? I don't know. My kids think this is okay, but I don't. But it may work. You never know. So we need to keep an open mind of how do we reach? Because I think the biggest issue we're going to have is we can only help the patients that we see. How can we increase our reach to the patients that we cannot touch? And so I think we have to embrace technology to figure out how to reach hard-to-reach places using virtual platforms, and maybe also having multiple hepatologists who wear VR sets. So I'll stop there. Thank you again.
Thank you, Dr. Ashani. Your talk was very inspiring. And we are continuing with the Dr. Coşkun Demirtaş. He's going to talk about the practical approach to the alcohol-associated hepatitis.
Thank you so much. So in the next 20 minutes, I will try to provide a summary about the practical approach for patients with alcohol-associated hepatitis. So we do all know that the harmful use of alcohol is associated with significant amount of morbidity and mortality worldwide. So it has an impact over 200 diseases, with most deaths attributable to cardiovascular diseases, injuries, cancers, but also the alcohol-associated liver disease, which is actually, the burden of it is on rise, not only in Western countries, but globally, and it remains a major public health concern which consistently had a lower representation among the liver transplant population, which became the #1 reason for liver transplantation in United States, and it comes after chronic hepatitis B and MASLD in Turkey right now. So the alcohol-associated liver disease, the term represents a spectrum of liver injury from simple steatosis to ASH, and to cirrhosis and ACLF and HCC, which the spectrum depends on the continued heavy alcohol use and the risk factors beyond alcohol use. So looking at the risk factors beyond alcohol, we can talk about the genetic susceptibility. If you have one of these single nucleotide polymorphisms, that you may have a higher risk for developing alcohol-associated liver disease. And if you have metabolic syndrome or risk factors, cardiometabolic risk factors, that you will have a higher risk for developing alcohol-associated liver disease. So what we can do in the clinical practice is that just assessing these risk factors and quantifying the alcohol consumption, which we basically what we do is to take all of these drinks to standardize it, to quantify it as 10 to 14 grams of alcohol, and then we are able to calculate the heavy episodic drinking and the binge drinking in these patients. So what many studies told us is that the up to 2 drinks per day for men and one drink per day for women is considered to be safe for the majority of population, but not for the chronic liver disease. Now we know that if the patient has an existing any other chronic liver disease, that there is no safe amount of alcohol consumption for these patients, and especially your attitude for drinking can identify your risk for the advanced alcohol liver disease, including if you're a binge drinker, or if you drink outside of meals, or if you prefer spirits instead of beer and wine, then you have a higher risk for alcohol-associated liver disease. So this has been talked in the previous talk. So there is probably no safe amount of alcohol for those who are obese and type 2 diabetes, or who has cardiometabolic risk factors as well. So after quantifying the alcohol use of patient, then what we need to do is to screen for alcohol use disorder in clinical practice. We have several tools to standardize this. We have the audit, which has 10 questions, which questions consumption, dependence, and alcohol-related problems. So we have the audit C, which is faster, you can only ask the first 3 questions, and the NIA recommends to ask the 3rd question only, and if it's positive, then to ask this whole audit questionnaire again. So what we need to do is to detect these patients with alcohol use disorder, and then when we catch them, whatever tool we use, then we need to provide brief motivational interventions to these patients and refer more severe cases for treatment. And if there is a suspicion for alcohol use in these patients, then we have very successful direct biomarkers for alcohol use, and the PATH test has been talked in the previous talk that it is highly reliable, that you can allow detection of chronic excessive alcohol up to 1 month in these patients, which can differentiate social drinking from alcohol abuse. So we have these tools, but the diagnosis of alcoholic hepatitis, that still can be challenging sometimes, that these patients can come to us with broad spectrum of clinical presentation. And if these patients comes up with a liver failure picture, then it may be sometimes hard to differentiate an acute liver failure, which does not have a pre-existing liver disease, or an ACLF picture, which has a pre-existing liver disease, or your patient can come to you with an acute decompensation of an end-stage liver disease. So these kind of pictures, clinical scenarios, can interfere with each other. And to standardize this, we have this NIA diagnostic criteria, which has been proposed in 2016, to standardize patients eligible for treatment and eligibility for clinical trials. But it is useful to categorize patients as definite, probable, or possible alcohol-associated hepatitis. In definite, there's clinical diagnosis with biopsy proven, and in probable, there's clinical diagnosis without potential confounding factors. Well, if there's clinical diagnosis with potential confounding factors, then your patient requires a liver biopsy to reach the diagnosis of alcohol-associated hepatitis. So the NIA recommends to make the clinical diagnosis of alcohol-associated hepatitis when your patient has an onset of jaundice within prior 8 weeks, and there should be an ongoing consumption above 6 months, and there should not be an abstinence for less than 2 months, and the ASD levels should be more than 50, ASD to ALT ratio should be more than 1.5, and the both values should be below 400. So, and total bilirubin should be above 3. So if there's presence of an atypical laboratory test, or if there's a possible interference of another liver disease, if there's a suspicion of another liver disease, let's say if there's a possible drug-induced liver injury, then we need to perform liver biopsy to differentiate, which will probably give you something like a MASH picture, but at least that will allow you to resolve the diagnostic dilemmas in presence of other confounding factors. So thinking about the interference of clinical pictures, are non-invasive fibrosis markers reliable in alcoholic liver disease? Yes, in alcoholic liver disease, but not in acute presentation of an alcohol hepatitis, because it will usually overestimate the fibrosis due to inflammation, so it will probably not be helpful for you to identify if your patient has a pre-existing liver disease or not. So now you diagnose the clinical, now you have the acute alcohol hepatitis diagnosis. Then the next thing we need to do is identify the severity of these patients so that we can identify the mortality, prognosis, and the candidacy for treatment. We have MADRS discriminant factor. We have several scoring models to identify the prognosis. The MADRS is the classic one. We have been using it for ages, and it can predict the short-term mortality, but it is less successful in predicting intermediate to long-term mortality, but it is still the key inclusion criteria in most trials because all the evidence in the literature is made with the MADRS discriminant factor. So nowadays, we use MELD score more frequently because the newer data suggests that the MELD score can predict the intermediate, and can provide a dynamic evaluation even if your patient is in the liver transplant wait list. But this is the MELD original score, not the MELD 3 or not the MELD sodium score, but the newer data also suggests that they can also be successful. And now we also, for the clinical practice, we also use Lille score, which actually aims to identify the steroid response, which provides at day 4 and day 7 to identify those with steroid responders and those who does not. So taking an overview of this algorithm, we have the diagnosis, and then after you have the clinical diagnosis of alcohol hepatitis, the first thing we need to do is to provide a general measure for these patients, starting with the complete abstinence, which is the mainstay of the long-term prognosis. And then we need to provide an adequate supplementation that these patients require, especially with the vitamin B complex for the Wernicke's encephalopathy prophylaxis, and arguably a zinc supplementation because the majority of these patients are zinc deficient. And we need to provide an adequate calorie intake, and we need to provide an adequate protein intake for these patients. And then we assess the severity with the combination of MADRS discriminant factor and the MELD score. And if the scores are low of their threshold, then we can consider this patient to have a mild to moderate alcohol hepatitis, which does not require any specific therapy, and the majority will resolve spontaneously. But these patients require an ongoing follow-up for the referral to the alcohol addiction treatment specialist, and if required, a long-term relapse-preventing drugs. But if the MADRS score is above 32 and the MELD score is above 20, then we need to take a minute to consider this patient, that this patient is a severe alcohol hepatitis, and we have this therapy option, which is prednisolone for this patient. So then we need to assess the contraindications if your patient is eligible for a steroid therapy and if your patient is going to benefit from that. The contraindications would be uncontrolled infections, acute kidney injury, uncontrolled upper GI bleeding, concomitant disease that would prevent you from giving steroid to this patient, and a multi-organ failure or shock. So if there is no contraindication for steroid therapy, then you start prednisolone 40 milligrams per day with the intention of treating this patient for 28 days, and usually adding a NAC infusion to these patients is recommended. So after starting this steroid and NAC combination therapy, then we need to assess the steroid response either in the 4th day or the 7th day. But usually the older algorithms suggest assessing treatment response at 7 days with the Lille score. And if the Lille score is above 0.45, this means that your patient is probably not going to benefit from steroids, but will only get the complications, including the infections. So you need to consider stopping treatment and then assess if your patient can be eligible for an early liver transplant. But if the Lille score at day 7, if the Lille score is below 0.45, then we continue treatment for 28 days and then stop treatment with very short-term tapering. So the question comes up of why do we give prednisolone to these patients? First of all, the first trial started with prednisolone. Prednisolone does not have a first pass effect in the hepatic, it doesn't go through a hepatic metabolism, and there are positive data before 2015 about pentoxifillin, especially with the lower rates of hepatorenal syndrome. But after this study in 2015, that we stopped giving pentoxifillin because this study showed us that prednisolone can provide a trend for lower mortality at 1 month, but not in 90 days and 1 year. So the further data, that 5 randomized controlled trials that showed us that prednisolone improves 1 month mortality, but not 6 month mortality, and no benefit of pentoxifillin combination has been provided. So another question comes up, who would benefit more from steroid therapy? Or because as you can see, the data has been controversial for a while, but this is the mainstay of therapy. So we got an answer for that question in 2021 with the study that the MELT score, if your patient has a MELT score between 25 to 39, probably your patient is the optimal group that will benefit from steroid therapy. But if your patient has a MELT score above 39, that probably there's a lower chance of benefiting from steroid therapy regarding the 1 month mortality. So maybe these patients will be a better candidate for an early liver transplant or a palliative therapy. So, but we do not have very quality data for the MAD risk discriminant factor for upper threshold. So you can use the MELT score to decide on to predict if your patient is going to be benefit from steroid therapy. So there is no direct recommendation for not giving steroids after MELT score above 40, but this is something that we should consider in clinical practice. And one other question is that, let's say your patient has, as I have told you earlier, that it may be hard to differentiate these clinical pictures from each other. If your patient has an alcohol-associated ACLF, then your steroid response gets lower with the increasing grades of ACLF. So this is also something that we should consider, that if your patient has more than 2 organ failures, that probably this patient is not going to benefit from steroids, but 1 to 2 organ failures, that you might still have an acceptable steroid response in these patients. And why do we give NAC addition to these patients is that mainly due to its safety profile, but this study from 2015 showed us that adding NAC infusion to prednisolone can also provide a lower mortality at one month and lower death due to hepatorenal syndrome. And then this has been proven with the further data that comparing with the corticosteroids alone, that addition of NAC can provide an improvement in the 1 month survival, but no benefit has been demonstrated for the 3 months to 1 year as well. So another question is that infection is one of the main determinants of the mortality of these patients, and these patients get infected at the baseline, at the clinical presentation, or these patients can get infected during the steroid therapy or even after the steroid therapy. So this data showed us that having a high bacterial DNA, that your patient might get an infection. This can determine the mortality. But patients presenting with infection, but who do not receive prednisolone, antibiotics does not impact upon mortality. But Those who receive prednisone and concurrent antibiotic therapy significantly reduces mortality. So thinking about that, how about we give prophylactic antibiotics during the steroid therapy? But although it makes sense in theoretical opinion, but in clinical trials, that it failed to show, including the amoxicillin clavulanate and meropenem and vancomycin and rifaximin, none of them have been able to show a benefit regarding the 90-day mortality for these patients. So the steroids have been the mainstay of the therapy. We do not recommend pentoxifilin or GCSF unless proven otherwise for now. But we recommend to give NAC infusion, NAC addition to these patients, mainly due to its safety profile and little evidence in the literature. So many drugs failed, including the prophylactic antibiotics, including the interleukin-1 antagonists and the antioxidant cocktails. Some drugs have terminated early due to higher infection rates at the beginning of the study. And for the to-be-evaluated box, there's fecal microbiome transplantation that the idea is to restore the altered gut mucosal barrier, that it might decrease the liver endotoxins and the inflammation. And so for now, we have small number of patient studies that showing us that it may actually have a benefit on the third month mortality, but the main concern here is the increased infection itself with the fecal microbiota transplantation. And another question for the future is that whether these mesh drugs, whether they will find a place for themselves in the management of alcoholic liver disease mainly. So after talking about the medical management, so who should be considered for liver transplantation? So we usually, we have been strictly adhering to the rule of the 6-month rule for the liver transplantation, but now that there's a shift towards performing early liver transplantation in selected patients, which are severe alcohol hepatitis, non-response to medical therapy, but this is not enough, then your patient must have presence of strong social support network, insight to disease process, that the patient, you should be have a consensus with the patient that the patient understands the disease process and should stop drinking in the absence of coexisting psychiatric disorders, agreement with adherence to lifelong abstinence, and complete agreement by the liver transplant committee. So this approach has started in 2011, that this study showed us that if we strictly select these patients and send these patients to early liver transplantation, they will have improved survival outcomes. We changed the notion in the 6-month rule approach. So 6 studies then, since 2011, showed us that if you send these patients to early liver transplantation, that these patients will have at least 70%, but probably more than 90% survival. But the problem here is almost 1/3 of these patients may turn back to drinking, and 10 to 20% of these patients may turn back to harmful drinking, which highlights the importance of the careful evaluation before liver transplantation and ongoing care after the liver transplantation as well. So with the significant increase towards alcohol-associated cirrhosis, the alcohol-associated hepatitis burden is also on rise in the liver transplant etiology, with less strict adherence to 6-month rule, but it is still below 5%. And we have some tools that you can consider to predict sustained alcohol use. They are mainly successful in exclusion. But what we need for the future is that in accurate, objective, standardized, validated patient selection tool to standardize this patient selection criteria. But until then, we will keep evaluating these patients regarding their psychosocial domains, including the family support and the insight, especially of these patients. And after the liver transplantation, our job is not done yet. Then we need to provide a post-transplant alcohol use disorder management for these patients, especially with a multidisciplinary integrated care team. So to conclude, the proportion of alcohol hepatitis is on rise, and we need to recognize these patients, and after providing the general measures, we need to determine the severity, and we need to identify those who will benefit from steroid therapies, and we should carefully select candidates for steroid therapy, and then dynamically follow these patients for the steroid response and the candidacy for early liver transplantation. And throughout all this process, we need to provide these patients a multidisciplinary integrated care team with the attendance of family members and the patient as well. Thank you.
Thank you very much, Dr. Demirtaş. This very good presentation. Before moving to the case discussion, we are inviting the three speakers to the stage. Please. Therefore, case presentation will be more interactive. Thank you. And the first presenter is the Dr. Volkan Yılmaz. Please, Yılmaz.
Thank the organizing committee for opportunity. I am Volkan Yılmaz from Ankara University, and I would like to present today's case for LAD. Our patient, 44-year-old male patient, presented to ER with jaundice, lost appetite, and fatigue for the past couple of weeks. Past medical history, notable forgot, no prior history of liver disease. He medication, colchicine, no other past medical history and meds, no history of family liver disease. He is a smoker and 25 pack per year, and he had been consuming 70 cc per day vodka for 2 years. He has been consuming alcohol for 20 years. BMI is normal. The patient was oriented to time, place, and person and was fully conscious. No asterixis. Vitals are stable. Jaundice of skin and sclera. On admission to the hospital, total bilirubin was 19.4. Direct bilirubin was 13.7. AST and cholestatic enzymes and leukocytes were high, and there was hypoalbuminemia. We hospitalized the patient. Laboratory investigation, viral and autoimmune serology was negative. Ceruloplasmin and ferritin level was normal. No drugs or herbal use. Hepatobiliary ultrasonography revealed hepatomegaly and grade 3 hepatosteatosis. MED-RIS discriminating function 63.6 and Glasgow alcoholic hepatitis score 9. What is the next step? What should we do next?
Now, we want to ask to the faculty, what's your approach to this patient? Yes. He's been using high level of alcohol and he's gotten high bilirubin levels.
Yes.
So the clinical suspicion is for alcohol-associated hepatitis. Of course, the question always becomes, what do you do with the white count? Majority of the time, the white count is probably driven by the ALCAP itself. What we clinically do is, if a patient like this came to us, he's sick but sounds stable, is that we would give it a day, potentially rule out infection.
No.
Before so no infection.
No infection.
Yeah. So I think we would, before the discussion of steroids, I think, we would probably give it 1 to 2 days to see if just naturally the patient improves before committing the patient to steroids.
We started hydration and electrolyte replacement treatment.
Just wait. Okay. You want to recommend?
No, just one, I guess 2 comments. So I might consider giving this patient steroids because I think earlier intervention is more effective, but I will say that I don't think that he's actually drinking 20 grams of alcohol a day. So I would definitely do a PEth in this patient just out of, care. I would be shocked. You can't get LCAP with 20 grams a day, I don't think.
Would you tell us the MELT score in this patient, in this step?
22.
Dr. Zeki Karasu.
In my opinion, there is an important issue to decide to start steroids for those patients. I closely checked the literature showing good results of steroids. In 5 of them, they started steroids in all 5 studies. that Joshkun showed the graphs. They started steroids after 5 or 6 days because to make sure patient does not have any infection, you need to wait for whole culture workup. Before you do not see all the cultures negative, starting steroids are too much dangerous. Usually, most of our colleagues skip that point. They just start steroids. Surely, steroids may play a good role, but you should definitely make sure that the patient does not have any infection.
But in our center, we do not use that kind of approach. We start steroids earlier. What's your approach? You wait or you start earlier?
I think this patient is a perfect candidate for steroid therapy regarding there's no confounding factors probably, as the doctor told us. So this patient has a severe alcohol hepatitis, but taking a moment to consider the contraindications is definitely required. But the contraindication here is an uncontrolled infection. So let's say if this patient is prone to infections, that this patient has a hidden infection for these patients, because these patients we don't know if this patient has a pre-existing liver disease as well. So this patient can be considered even immunosuppressive. So this patient can have a hidden infection, but still this patient is a candidate for steroid therapy, and then we can discuss having a low threshold for antibiotic starting. So let's say if there's a very little suspicion of antibiotic, not like a prophylactic antibiotic, but like having a very low threshold and starting a direct empiric antibiotic, a strong antibiotic. This is what I think.
Lab test, please. Lab test.
Yeah, just one more comment about that. So I agree that infection needs to be ruled out, but in a patient like this, if they do not have hypotension or, clinical evidence of severe infection, if they have no fever or hypothermia, if they have a clear chest x-ray and if their urine is fine, and if they have ascites that you don't have SPP, all that information you can get within 24 hours. So I would say that's why I would do a targeted infection workup, and, blood cultures will be sent, of course, but the reality is most of these patients do not have an uncontrolled infection. They have ALCAP and the leukocytosis is from that.
And also we have got an elevated RNA and low levels of albumin, but no thrombocytopenia. Is that matter? Is this important for your decision?
I think in an acute presentation that it can mimic a chronic liver disease. So this does not mean that this patient has a pre-existing liver disease. Sometimes they can mimic a de novo onset portal hypertension, and even if this patient has slight thrombocytopenia, this still does not mean that this patient has a pre-existing. In this severe alcohol hepatitis presentation, this can definitely mimic a chronic liver disease presentation.
Okay. We may continue now.
This table presents the trend of laboratory parameters historic methylprednisolone therapy, demonstrating a decrease in bilirubin levels. GGT and LAP decrease, INR stable, albumin decrease, creatine is stable. Here is day 3. Here is day 5. Total bilirubin decrease, and AST and LAT stable, GGT and LAP decrease, INR decrease, albumin is stable. What we the next step? What we do next step?
So if you can go back to the labs, please. Yeah. So already, the first argument was, steroids or not, and would still say, sometimes just waiting you may not even need steroids. But let's say in this case, you've decided that this patient has no infection, is stable, and you've given, in this case, methylprednisolone. You're already seeing that by day 5, you've had a response. And when you think about the Lille score, the primary determinant in the Lille score is your bilirubin. So already by seeing the delta bilirubin, you're seeing a response. So if you're seeing a response, I think the next question is just, do you just continue for the next 4 weeks or no? And hence the discussion about taper versus keep the same dose.
Yeah, this is also what I thought, like to give the same dose for 28 days, or maybe start tapering the dose with this direct, very, very quick response that maybe should we discuss starting tapering and after the second week. So this is not what is recommended if you read the guidelines, but maybe starting early tapering, because exposure of steroid, if it is like when there's a prolonged exposure of steroid, that we might have a negative impact for the outcomes of these patients. But I would probably at week 2, let's say, I don't have very good data to say week 2, but usually, like not 4 weeks, but starting from week 2, that we can start discussing a very short tapering response, maybe stopping the treatment in 1 month, if there is a very quick response like this.
Yeah, I would agree. That's a dramatic response. So I think you could tolerate giving less. The other thing that maybe we're going to talk about later is the importance of nutrition. So this patient is, we don't usually use those parameters for albumin, but I believe they were hypoalbuminemic based on that. So nutrition is just very important in these patients as well.
Lille model for alcoholic hepatitis on day 7, 0.02. And
okay, you can continue.
We continue the steroid treatment and gradually reduce its dose. The patient was then discharged. So then laboratory test results 28 days after discharge, total bilirubin level is decreased, AST, ALT decrease, GGT and LAP decrease, INR decrease, albumin levels normal, creatinine level normal. Thank you.
So the patient is quite well now. So what do we recommend to the patient for the future?
Counseling and medications for craving is what I would do.
But in the best circumstances, 1/3 of the patients continue drinking. And do we have any measures that to have his in the keep it in safe way? Do we have any?
Yes, the linkage after the discharge, as you were saying, is probably as important as the treatment. And that's the paradigm shift that, how can we still impact and not just say refer to psychology? Because that's been hard. So even in our clinic, we struggle with this all the time. So hopefully the patient will show up back in clinic. That's one. Family involvement is 2. And what we've been doing is, we have access to Alcoholics Anonymous, which is a free support system for alcohol in the community. And now what we've been doing is actually virtual options. So there's a website, you can go virtually. So we try to encourage our patient to do that. With regards to alcohol dependence medications, such as naltrexone, we want to see some commitment that the patient will come back. And if they're craving, then, as they get slightly better, we would start that.
I would not add too much, but our job's not done yet here. So actually, the job starts after here, probably for the prognosis of these patients. But it depends on the, for these patients, what we can provide is brief motivational interventions in clinical practice, which I think is not something that we sometimes say that, okay, this is not our profession. We resolve the organic problem. So now it's psychologist or psychiatrist term. But usually the patient relies on you as a physician. So I think the patient wants to hear it from your mouth. So that if you take a few minutes and provide a brief motivational intervention, and then the patient will take it seriously. Of course, addiction specialist is also important, but somehow that, because this really had a dramatic response, that the patient may think that, okay, so it's okay. It's like something getting infection. So we need to take a minute to tell the prognosis and what will happen next if the patient keeps drinking.
Any question or any comment? Please, Dilman.
Thank you very much. Great presentation and discussion. Do you recommend the steroid treatment for alcoholic hepatitis patient with ascites with antibiotic prophylaxis, and which antibiotic do you use in clinical practice?
So this is for a patient who admitted with severe alcohol hepatitis, and you think, and ascites. I don't know. I mean, it's so even like now we've, after that, the N-acetylcysteine. So I would say in our group of now 25 hepatologists or so, half will never do steroids, half will think of steroids. So already about steroids, there's a debate. Out of the half that do steroids, some will try N-acetylcysteine, and maybe one or two will think about prophylactic antibiotics. And my guess would be we would probably do ciprofloxacin or levaquin, but that is just empiric.
So I would agree. I was smiling that about 50% of our hepatologists will use or consider steroids, and 50% never do. I'm in the half that does consider steroids because I do think in well-selected patients they're a good idea. As far as antibiotic, would the presence of ascites change my decision? I would just rule out SBP like I would in every single patient that comes to the hospital with ascites. It's important to do that. And generally, I would prophylax that patient with either a quinolone or a third-generation cephalosporin while they're in the hospital, or, again, low total protein, et cetera. But generally, they're going to get prophylaxis.
I think that would be that one clinical parameter that went to decide on prophylaxis antibiotics, because in the presence of ascites, that let's say if this patient was like a variceal bleeding patient, so we would consider this patient as a candidate for prophylactic antibiotics. Although we do not have very good data for this, that would be one thing that I would look for. If the patient has an ascites, then I would have a very low threshold for considering prophylactic antibiotics or starting antibiotics, even with a little suspicion.
Thank you very much, Dr. Yilmaz, for nice presentation. Next case presentation is going to present Dr. İlker Şen. Please.
Good afternoon to all, and heart welcome to colleagues from US. The second case will be discussed by me. My name is İlker Şen. Can we start slides? Okay. This second case is male patient, 37 years old, admitted to emergency department with complaints of jaundice, nausea, and fatigue for 2 weeks and worsening at the last 4 or 5 days. Past medical history, family history is not significant. Alcohol use disorder for 15 years, 3 units daily, approximately. On physical examination, it was conscious, orientated, icterus was positive, tenderness on the rock, BMI 26.5. Tests on admission, you see liver enzymes, ALP, GGT, total bilirubin elevations, creatine 2.07, hyponatremia, hypokalemia, CBC count, white blood cell high, platelet normal, hemoglobin 10 nearly, macrocytic anemia, INR 2.5, CRP 25, MELT score 33, FIB4 2.84. And we made diagnostic workup to exclude the other etiology for acute hepatitis. All tests were negative, but the anti-HBC total. Ultrasonography findings patients were like this: hepatomegaly, smooth surface, marked increased echogenicity in parenchyma, no intrahepatic dilatation, portal vein flow and hepatic venous system flow were normal. Spleen is of normal size and shape. And here is the CT scan, very large liver. What should we do next?
So compared to the first patient, I mean, this patient, on presentation is sicker. The patient is hyponatremic, has elevated creatinine, leukocytosis, as previously seen, and the MEL score is already above 30. So even though he or she may not have absolute contraindication to steroid, this is a patient I would hold off on steroids, and the first thing would be infection, supportive care, and nutrition.
Thank you. Calculated discriminant fraction is 92, and we started steroid the patient. And also we assessed patients for alcohol withdrawal syndrome. A clinical institute withdrawal assessment for alcohol scale, it was 8. Psychiatric consultation, after psychiatric consultation, diazepam, BID started to patient, and vitamin B complex intravenous infusion also started to patient. Also nutritional support, management done. And we assessed the corticosteroid response at day 4, latest data. On literature says day 4 and day 7 are equally strong to determine the answer. So we calculated day 4, it was 0.444 points. It says us to go on. But I wonder, it was just above the cutoff level. Should we stop the steroid? What do you think about it?
First of all, what I think about initially for this patient is, should we assess this patient as an acute alcohol-associated hepatitis, or is it an ACLF picture? That this patient already has a high creatinine level, so should we consider this as an organ failure? This does not change our approach, definitely. So this is not a contraindication for the steroids initiation. But now we have a partial response, and the Lewis score is at day 4, it is below the threshold. I think we should continue with the treatment without stopping. And at day 7, we should calculate the Lewis score again and then decide afterwards.
Okay, we've gone at the Lewis score at the day 7 was 9.3. It was make the decision to continue the therapy. But when we decided to continue therapy, at the test, workup test, anti-HBC total was positive. What should we do? Would you start treatment or just follow up? What decisions should we?
So in the population that I treat, the prevalence of hepatitis B is low, and core antibody positivity is a common false positive. But in your population, the prevalence of hepatitis B is high. So I would check the DNA level, and I'm not sure that I would actually give antiviral therapy to this patient, but I think you could, and you could probably use something even like lamivudine, because if the viral is negative, you could use something inexpensive like that. But I'm sort of on the fence about that. I don't know if I would give it or not, but of course the DNA is negative, right?
Yes.
Same thing, I mean, I saw core antibody was positive, surface antibody was positive. Both
only core.
Only core was positive. Same thing we see so much. I think the question for, again, low prevalence is, since we see a lot, and if you're not thinking prolonged immunosuppression, then why give it, depending on if you're going to taper or not.
So maybe, this is something we do not very much consider in patients with alcoholism, that we do not specifically look for this. So now that the question just came, so if there's a core antibody positivity, that normally if this patient will get more than 4 weeks of therapy, that this patient requires antiviral. I mean, we can discuss antivirals. So basically, I think maybe the approach for this patient can be to wait for the 4 to 7 days for the Lille score, and if the steroid exposure will prolong, then we can discuss antiviral prophylaxis. Or if we are going to stop the steroid therapy, then there's no sense of giving antiviral therapy to this patient.
We started. And the cover.
Just wait.
Sorry, Ilker. I mean, especially this case, when you assess the treatment steroid response, Lille score is slightly decreased in this case. Do you use delta bilirubin or Lille score or both?
I think for this would be just, for me it would be just the delta MELD direct, sorry, the total bilirubin, just to see if it's changed or not.
We determined that it will therapy will be longer than 14 days. Nearly 1 month we started antiviral, 0.5 milligram day dose, and the course of the bilirubin levels, as you see on the chart, and INR levels. The patient is smiling, doctor is smiling, but at the day 9, dyspnea, cough, and subfebrile fever occurred. The patient, on physical examination, basal zone of right hemithorax, the respiratory sounds were diminished. We couldn't exclude nosocomial infection, aspiration, even he's not using alcohol, but we couldn't rule out it. He's under steroid treatment. The chest X-ray, day 1, and the chest X-rays on the right, day 10, you see, and the parameters, you can compare day 1 and day 10. And CT scan after this condition. After infectious disease evaluation, meropenem, 1 gram BID IV according to EGFR calculation empirically started. Also, we obtained blood, urine, and deep tracheal aspiration. Blood and urine test was negative, but deep tracheal aspiration, so monas ruginosa positivity, we found it 82 hours later. We continued to meropenem. The CRP response to meropenem treatment was shown on the figure, chart, as you see. At the day of meropenem treatment, we experienced relapsing fever, increased acute phase reactance. We also obtained blood and urine cultures again, and we couldn't exclude MRSA. So we added vancomycin, has been added to current antibiotic regime. The cultures, urine culture, result obtained 48 hours later, Candida albicans positivity obtained. Anadula fungin has been added to meropenem and vancomycin. Blood culture was negative, and we obtained result at the 7th day of the culture. We discontinued vancomycin at the 7th day. And antibiotic treatment de-escalation, at the day of anadula fungin treatment, urine culture control was negative. We totally gave anadula fungin for 10 days. Clinical and biochemical response has been obtained, and the meropenem treatment continues for 21 days totally, and the chart of the total treatment, CRP course, and steroid durations below, you can see all the story here. And the laboratory tests on admission and discharge test, you see decrease this all in all parameters. Mass score was 3 again, 51.8. CRP and the rise and fall you can see on the table. CT scan 10 days after discharge was normal. And we always throw the steroid as a lifebuoy to a patient, but sometimes it may have thorns on it when the patient grabs it. We should always keep in mind the side effects. Thank you for listening.
Did you continue or discontinue steroids while this infections period?
We continued.
You continued. What would you do?
The chart summarized the treatment.
Doesn't matter. I think the boat's already sailed, so yeah. It's you know with the steroids. I mean, it's interesting. Like the gut reaction is to say, okay, stop steroids. You have caused an infection. But on the other hand, if you look in the ICU, patients get steroids all the time along with antibiotics. So whatever you want.
Okay.
So I hope this patient has a strong family support, and because they need a liver transplant, really. So that would be what I would be thinking about with this particular patient. The other thing I just want to comment on is that do you have PEth here? Do you use PEth?
PET?
Yeah.
Yeah, PET scan.
Oh, the phosphatidylethanol. No, because I know I'm fixating on this, but the amount of alcohol intake for somebody who comes in with that high of a MELD score, that sick, they're drinking a lot more than 3 drinks a day, a man, much more than that. So I wonder if there's a lot of underreporting here. We underreport in the United States too, but I'm wondering if that's an issue. And I bet you if you checked a PEth on this patient, it would be 1,400 or something like that.
Okay,
yeah.
Thank you.
Dr. Günşar?
Thank you.
But this is a very risky patient. He had very bad prognostic factors when you are starting the steroid therapy, and you suggest the supportive therapy first, vitamins, electrolytes, albumin, maybe antibiotics. Do you think the corticosteroid therapy a little while after the condition of the patients, and not in the beginning, after the 4 or 5 days, what's your opinion? Do you recommend like this treatment or follow-up?
So I think similar to what he was saying is that I think once you guarantee stability, and the patient's okay and talking to you, and overall you're less concerned about infection, the creatinine's better, then it's okay to give the give steroids for a short-term period.
What's your approach to the patients evaluating the Lilly score day 4? Generally use it. If it's over, then you will take preparation for the liver transplantation earlier than the day 7. What's your daily practice?
I use the low score. That's, I think, one of the reasons why we see less infection with steroids is because we know if there's no response at 4 days, then you're not going to see a response, and you're just basically increasing the risk of infection. So I use the low score definitely. And as far as liver transplantation, this person came in sick enough that there's no doubt that they would have, we'd be doing a very careful psychosocial evaluation, and if they met criteria for our program, we would be listing that person for transplant.
We would wait. I mean, I think so. We were a program five years ago, had the 6-month sobriety rule, and then started our clinic and got experience, and now have been doing patients such as these for the last 3-4 years. But we were compared to the other U.S. centers, we were one of the later ones. And our experience has been that if we can just get them out of the hospital for a week or 2, establish those things, then they may have a better outcome. And I think that's just different reasons.
Yeah, no, there's a lot of variability in the United States with respect to when you transplant somebody with alcohol hepatitis. But I would say the first patient was likely to get better, and you probably wouldn't need to do a liver transplant on that person if they maintain sobriety. But the second one is probably too far. I think too far advanced to really realistically think they're going to get that much better. Yeah.
Is there any yes, Dr. Ilman?
Thank you. Based on the AASLD guideline about the ACLF, is this patient ACLF or acute severe alcoholic hepatitis? Yeah, or it doesn't matter, whatever it.
So with the ACLF, so in terms of the guidance that we came up with is evidence of extrahepatic organ failure. In this case, the patient sort of was heading that way. Question is how do you define what is the extrahepatic organ failure? In this one, the only one closest would be the creatinine, but the patient is not on dialysis yet. So I would say he's sort of almost there, but not there per the AASLD guidelines. The second aspect is we're actually trying to work as a follow-up to that to identify when we say somebody has AASLD guidelines, extrahepatic organ failure, what the cutoffs should be, and that is work undergoing right now.
I think this patient can be considered like a ACLF grade 1-ish, not maybe a grade 1 ACLF, but almost grade 1 ACLF if you consider the AASL guidelines or the other guidelines. So, but it definitely will not change our approach regarding the steroid initiation. And for that, maybe if there was more than 2 or 3 organ failures, then we can. Then, if there was a established ACLF picture with 2 or 3 organ failures, then we should definitely discuss if this patient will benefit from steroid or not. Because as I have shown earlier, that the steroid response from we don't have not that much data for ACLF, but the steroid response diminishes below 40%. So this maybe still acceptable for these patients, but and then the early liver, or maybe we should consider little score calculating at 4th day maybe, and then like a fast approach to early liver transplantation can be considered as well. I wanted to ask a question to both of you. So let's say if your patient does not respond to steroid, and then and your patient is a definite candidate for an early liver transplant, never had a prior attack of alcohol hepatitis, and has a very good insight. So what is the period of time from that point to reaching the liver transplantation in your centers? So, and what is the liver transplant wait list for these patients in your centers?
So if we think they're a candidate, then it just depends on local factors of when you get an organ. An example in our center, time to transplant for all comers once they're listed is about 2 to 3 weeks. So now at least we're more aggressive in terms of organs, and so it's less time.
At our center, we transplant. We have 5 centers in Chicago, so we transplant at a much higher MELD score in general. So usually these patients have very, very high MELD scores, so they're going to get an organ offer pretty quickly. If we can do a workup within 48 hours, it's possible that within the week you can get a transplant on that patient if their MELD score is that high, especially if they're a favorable blood group. And also a big difference between here and the U.S. is that we do mostly cadaveric donors as opposed to living donors, and also living donors may not have enough liver to give to help somebody who's as sick as this.
So I want a big applause for the faculty for nice discussions and presentations. Thank you very much for your contribution.
Thank you so much. I appreciate it.